Good evening, friends. So today, as suggested by one student, she or he's asked me whether I will be able to teach you about pupillary reactions and abnormal pupils. So I'm taking this lecture to teach you about pupils. So let us start this lecture now. Let me share the screen of a PowerPoint. So what is normal pupils, friends? Pupil is very important structure in the body. It's like a window to the brain. The pupils, the size and the reaction not only tell us about the abnormalities of the eye, but it tells about the abnormalities of the brain also. So every one of you should be able to elicit and interpret the pupillary reactions. So what is normal pupil? Pupil is an opening located in the center of iris that allows the light to enter the retina. The size of the pupil determines the amount of light that enters the eye. If the pupil is dilated, then more light will enter the eye, and this depends upon the ambient illumination. If the ambient illumination is dark, then naturally the pupils will be dilated, so more amount will enter the eye. If the illumination is bright, then the pupil size will be smaller. So the pupil size is controlled by the muscles which are present in the iris, which dilate and constrict the pupils. So these are nothing but dilator and sphincter muscles of the eye. Normally there is one pupil. Very rarely there are two pupils in the eye. That condition is called as polychoria, as seen in this photograph. And the pupil is almost central, but sometimes it is eccentric. So that is not also normal. That is called as coractopia. The size of the pupil varies, friends, from 2.5 millimeter to 4 millimeter, depending upon the illumination. The myotic pupils are usually less than 2 millimeters, whereas mediatic pupils are more than 7 millimeters. So what are the pointers towards an abnormal pupil? You always compare the size of the pupil in both eyes. If it is unequal, then there may be some abnormality. If the pupil is not reacting to the light, or if it is not in center, or if it is irregular, and or if the pupil is dilated and constricted, then it may be abnormal. So it regulates the amount of light enters the eye, and it also reduces the spherical and chromatic aberrations and improves the depth of the focus. And it also allows the passage of aqueous humor from the posterior chamber to the anterior chamber. So the iris contains two groups of smooth muscles, a circular group or a muscle placed circularly concentrically, that is called a sphincter pupillae, and a radial muscle, that is dilator iris. Okay. So these are the muscles. So this sphincter pupillae are concentrically arranged around the pupil, and they are supplied by these parasympathetic nerves through the third nerve. And when they are stimulated, the sphincter pupillae will contract, and it causes pupillary constriction. Whereas these dilator iris muscles are radially situated, and they are stimulated by sympathetic nerve. So when there is a sympathetic stimulation, like when we are in stress or when there is fear, then there is sympathetic hyperactivity. When we are excited, then there is sympathetic hyperactivity, and it causes dilatation of pupils. Okay. Just there is some technical problem, so I'm not able to move to the next slide. Let me try. Let me share the screen again. Yes. So let us hope that I would be able to go to the next slide. Yes. So the pupillary reflexes are basically the most important reflex is light reflex, and there is near reflex, and there is swinging flashlight test. Usually, swinging flashlight test is nothing but a component of light reflex test only. So how do we assess this light reflex? This is very, very important, friends, and you should be able to assess the light reflex very correctly. It assesses the integrity of pupillary light pathway. So let us have some idea about light reflex. So as with any other reflex, there is a sensory receptor, then there is a afferent pathway, then there is a center in the brain, and then there is efferent pathway, and finally there is a muscle which will act. So the pupillary light reflex assesses the integrity of all this pathway. So how to perform this? In the dim ambient light, we have to ask the patient to look at a distant object to reduce or to relax the accommodation. And then when shine the on the right eye from the right side and on the left eye from the left side, and the pupil should constrict briskly. So what is the normal response? There should be a brisk, simultaneous, equal constriction of both pupils in response to light shown in one of the eye. For example, if I am shining the light in the right eye, both pupils will constrict equally. So this is because of the parasympathetic pathway. The first order of nerves start from the retina and they go to the brainstem in the pretectal nucleus. And the second order neurons go from pretectal nucleus to the Edinger vespal nucleus. And there is a bilateral innervation. Means the fibers go from right to left and right to right. So that's why there is consensual reflex. And the third order neurons start from the Edinger vespal nucleus to the ciliary ganglion, and the fourth order neuron from ciliary ganglion to the sphincter pupilli via short ciliary nerves, which is a branch of third nerve. So that is a parasympathetic pathway, friends. And what is sympathetic pathway? So the fibers start from hypothalamus, then they go to the ciliospinal center of Budge, which is situated in the cervical vertebrae, and from there it ascends to the superior cervical ganglion, and through the nerve fibers, sympathetic plexus, which is surrounding the internal carotid artery, it enters the brain, and through that, then it passes through the cavernous sinus and it enters the eye through the nasociliary nerve from the ophthalmic division of the fifth nerve. And from nasociliary nerve, it goes to the long ciliary nerve and it reaches the dilator iris muscle. So consensual right reflex is the right reflex mediated by the what happens in consensual light reflex. I am shining light in the right eye and there is equal simultaneous constriction of the left eye. That is consensual light reflex, and that is basic funda of this is because of the decussation or bilateral innervation from the pretectal nucleus to the both Edinger vespal nuclei. So this is a sympathetic pathway, friends, which I have already told you. The first order neurons start from posterior hypothalamus to the ciliospinal center of the budge. It is uncrossed in the brainstem. The second order neurons from ciliary center of the budge to superior cervical ganglion. And the third order neuron from superior cervical ganglion to the dilator pupillary muscle via nasociliary and long ciliary nerves. So this picture shows beautifully what is direct and what is consensual pupillary reaction. So how do you see the near reflex? See, in near reflex, what we have to do is we have to instruct the patient to look at a distant target and then bring an object to the near point and observe the pupillary reflex. When the patient focus shifts from the distant target to the near target, there should be a brisk constriction normally. So this is how you test the near reflex. So the afferent stimulus here is carried by from retina via the optic nerve, and this is accommodation reflex pathway. Accommodation means when we want to see the near objects clearly, then the power of eye increases by constriction of the ciliary muscle, and at the same time there is constriction of the pupil also. So this is this diagram shows the how the accommodation reflex. What is the pathway of accommodation reflex? So how do we, a swinging flashlight test is very important, friends, because This test is a very sensitive test to detect optic nerve dysfunction, and that's why it's a very sensitive. So that's why you should be able to do, and that's why you should be able to do it properly. So how do we do it? Basically, what we do is, in a dim light room, you notice the size of the pupil, ask the patient look at a distant object, and then swing the beam of pen light torch back and forth from one pupil to the other and observe the size of pupils and reaction of pupils. Normally what happens when I'm shifting the light from the right eye to the left eye pupil becomes constricted, and the other eye also pupil also constricts. But when when there is dilatation of the pupils, for example, if I'm shifting the light from the right eye to the left eye, and the left pupil, instead of constricting, if it is dilating, that means that there is some problem in the afferent pathway of the left nerve. So that is called as relative afferent pupillary defect, and that is very beautifully and easily detected by the swinging flashlight test. So this shows, first what we have to do is shine light into the right eye, then slowly swing light from right to left and left to right. So what happens that always there will be constriction when I'm shifting light from right to left, there is constriction in the left eye. But if there is dilatation, that means that the afferent pupil in the left eye is abnormal, afferent pathway is abnormal. And this afferent pathway is nothing but, friends, it is made up of mostly optic nerve. So optic nerve, maybe there is some problem in the optic nerve. So these are the other pupillary reflexes. If I am applying pain to the neck, face and upper trunk, then because of the sympathetic innervation, the pupil dilates. So this is called as ciliospinal reflex, and this reflex is absent in Horner syndrome and lesions involving the cervical sympathetic fibers. So what are the disorders of pupil? So anisocoria means pupils in both eyes are not of the same size. There is a difference between of 0.4 millimeter between both eyes. So almost 20% of normal people have slight difference in pupillary size. That is physiological, but the difference is usually less than 1 millimeter. So if the larger pupil is abnormal, means there is a poor constriction in the larger pupil, then anisocoria will be greatest in bright pupil because the normal pupil becomes small, and this is usually caused by disruption of efferent pathway. Friends, efferent pathway not only comprises of the nerves, but it also concerns the muscles of iris also. For example, if there is third nerve palsy in the right eye, then the right eye pupil will be large and it will constrict poorly to the light. So this anisocoria will become greatest in the bright illumination. Otherwise, if there is some problem in the sphincter, for example, trauma to the eye causes traumatic mydriasis. This is because damage to the sphincter. In that also, the large pupil is abnormal and the anisocoria will be greatest in the bright illumination. And if the smaller pupil is abnormal, means the pupil is not dilating properly, it is dilating poorly, then the anisocoria will be greatest in the dark illumination, because in dark both pupils are supposed to dilate. Here normal pupil will become large, but this our pupil, the smaller pupil, will remain small, and this is caused by disruption of sympathetic pathway. So what is mydriasis? Mydriasis means dilatation of pupils. So there are n number of causes of mydriasis. So they start from the neurological causes to the right up to the sphincter and drugs. So this mydriasis may be because of paralysis of parasympathetic fibers. That may be because of lesion right at the origin in the midbrain or along the course of the third cranial nerve. So it may be because of vascular accidents in midbrain and tentorial herniation or aneurysms of carotid artery. So what are the other causes? That Adistonic pupil, we'll discuss it in detail. Then post-traumatic iridoplasia means trauma to the iris will also cause dilated pupil. Then overdose of sympathetic drugs like amphetamine or cocaine will cause dilatation of pupil. And this belladonna or datura poisoning will cause dilatation of pupil. And drugs like atropine, homatropine, or sympathomimetic drugs like epinephrine, norepinephrine, phenylephrine will also cause dilatation of pupils. So remember, friends, these causes number 4, 5, and 6, pupils will be bilaterally dilated, whereas if there is trauma, usually that affected pupil will be dilated. So what is meiosis? It's opposite mydriasis. So if there is a lesion in the sympathetic pathway, which maybe in the along the course of this sympathetic reflex, we already touched upon the sympathetic pathway. So the lesion may be in the hypothalamus, in the brainstem, or in the spinal cord, or it may be in the cervical sympathetic ganglion or the sympathetic nerve. So it all of them will cause meiosis. So this is called as Horner syndrome. Then other causes of meiosis are Argill Robertson's pupil, then opiate poisoning, then hemorrhages in the pons, that is a part of brain, then organophosphorus poisoning, or drugs like pilocarpine, or old age, that is a physiological cause, that is called as senile meiosis, and drugs like pilocarpine, muscarine, and all. Sometimes the pupil constricted in unilaterally only in one eye. That is because of problem in that eye itself, maybe adhesions because of uveitis, or maybe because of pseudo exfoliation, the pupil will be small. So light near dissociation, this is very interesting. In this light near dissociation, what happens when I am focusing towards near, pupils will constrict. So that is called as near reflex. And pupils will also constrict to the light. That is called as light reflex. So light near dissociation is disparity between light reflex and near reflex. Near reflex is normal, but light reflex is poor. So that is called as light near dissociation. So this is because the fibers mediating the pupillary light reflex enter the dorsal brainstem, but the near response fibers ascend to the Edinger vespal nucleus from the ventral aspect. So, any lesion in the dorsal part of the brainstem, such as pretenctum and posterior commissure, impairs the light reaction. However, the fibers which mediate the near response will be spared. So, this is called as Argill Robertson pupil, in which these Argill Robertson people react poorly to the light but very well to the near reflex. So usually they are bilateral and symmetrical, and they are small, irregular in outline and have light near dissociation. That means that they react poorly to the light but very well to the near reflex. And the lesion rise in the brain, in the periaqueductal region, pretectal area, and dorsal part of brainstem basically. And this was a classical eye finding in neurosyphilis, okay, and other regions like aortic regurgitation. So always remember, accommodation reflex preserved and pupillary reflex absent. ARP means accommodation reflex present, and PRA means pupillary reflex absent. So then we'll discuss about, we have already discussed about afferent pupillary defect, which is detected by our swinging flashlight test. So absolute afferent pupillary defect is caused by complete optic region, optic nerve region, and relative afferent pupillary defect is caused by incomplete optic nerve region. So what happens in absolute afferent pupillary defect? The involved eye is completely blind, that is there is no light perception, and both eyes are equal in size normally, but when affected eye is stimulated by light, neither pupil will react. For example, अगर right eye में optic atrophy है complete, so when I am putting light in the right eye, neither right or nor left pupil will react. Whereas when I am stimulating the normal eye, both pupils will react, right as well as left. So this is called as absolute afferent pupillary defect. Whereas relative pupillary defect is caused by incomplete optic nerve lesion or severe retinal disease. And in this, there may be slight reaction in the affected eye of the, that is the difference between absolute and relative pupillary defect. So what happens, I have already told you, but again I am repeating it because it is very important. So when the normal left eye is stimulated, both pupils will constrict. But when the light is swung to the diseased right eye, both pupils dilate instead of constricting. So this is called as relative afferent pupillary defect, and this is classical sign of optic neuritis. Any problem in the optic nerve, such as optic neuritis or injury to the optic nerve because of trauma in head injury, or severe glaucoma, also can cause this relative afferent pupillary defect. So there are n number of causes of optic neuritis. We are not interested in discussing causes of optic neuritis right now, but afferent pathway में problem है, so there is relative afferent pupillary defect. And in oculomotor nerve palsy, it's an efferent pathway. Friends, oculomotor carries the efferent part of part of the light reflex. So it will cause dilatation of pupil in that affected eye. So how to differentiate between afferent and efferent lesions? So in afferent lesions, consensual will be normal in that eye. So right eye, if there is a optic nerve lesion, if I am putting the light in the left eye, right eye pupil will be constrict because efferent in the right eye is normal. But whereas here, suppose there is oculomotor nerve palsy in the right eye, then even if I am putting the light in the left eye, still the right pupil is not going to constrict because there is some problem in the efferent pathway. Okay. So that is about the oculomotor nerve pathway. So friends, in the third nerve palsy, there are basically third nerve palsy is because of mainly two reasons. Like one is a space occupying lesion which compresses on the third nerve, and because of vasculitis due to diabetes or hypertension. So in vasculitis because of diabetes and hypertension, usually the pupil is spared, but in the compressing lesions, in the lesions which compress, the pupil is not spared. So that is how we can differentiate between the cause of third nerve palsy by just looking at the pupil. So if other muscles are paralyzed and pupil is reacting, usually it is vascular lesion. But if pupil is also abnormal, then it is usually tumor or any other space occupying lesion. So now we'll discuss about Horner syndrome. So Horner syndrome is because of the affection of the sympathetic pathway, and this sympathetic pathway has got first order neurons, second order. This sympathetic pathway can be affected anywhere from first order neurons, second order neurons, and third order neurons. So what happens in Horner syndrome? Usually there is slight amount of ptosis because the tarsal muscle is also supplied by the Muller's muscle is supplied by the sympathetic nerve. So it will not also constrict and there will be slight ptosis, and there will be normal pupillary reactions to light and near, and there will be constriction of the pupil basically, and there may be color change in the iris and slight elevation of the inferior eyelid as a result of weakness of inferior tarsal muscle, and there will be reduced sweating on that side only if the lesion is below the superior cervical ganglion. So this is a Horner's pupil, friends, in the left eye. So how do we confirm Horner syndrome? So what happens that if just let us go back to this slide. So here the right eye. So how do we confirm Horner syndrome? We instill a drop of 4% cocaine in the affected eye. So in physiological anisocoria, it results in dilatation. But if there is Horner syndrome, there is no dilatation. So again, if you want to localize further, then we can add 1% hydroxyamphetamine, and pupillary dilatation in that after with 1% hydroxyamphetamine will suggest a central or preganglionic Horner syndrome, whereas the dilatation doesn't occur if the lesion is postganglionic, means posterior to the after superior cervical ganglion. So lastly, Adistonic pupil is nothing but a unilateral mydriatic pupil in otherwise healthy patients. This is because of the denervation of postganglionic supply of sphincter pupillae and ciliary muscle, which may follow a viral illness such as herpes zoster. And how does it look like? The affected pupil is large and regular, and there is sluggish reaction to the light, but normal near reflex. And redilatation after the near response is slow. And over months to years, the pupil will diminish in size to become myotic, and there may be diminished deep tendon reflex. So that is called as Homer's Addis syndrome. And how do we confirm the diagnosis, friends? It's very easy. We have pilocarpine drops available with us. So we dilute the pilocarpine drops by 10%, and then we put that drop in the abnormal pupil. So it will constrict vigorously with uh, even if with diluted drop, whereas the normal pupil may not constrict. So it is a benign condition. With the time, the accommodative response improves, while the tonicity of the light gets response worse, and there is no treatment, and patient assurance is important. So this is Addis pupil. And in Addis pupil, there will be slight writhing movement of the iris when we shine a light in the patient's eye. So how do we diagnose Addis pupil? Basically, we have to ask the history about any viral infection recently, and the patient's main symptom will be difficulty in near vision from the affected eye. So this hemianemic pupil is seen in patient optic lesions of the optic tract. So if we stimulate the affected part of the retina, then there will people will not show any reaction, while stimulating the normal retina, people shows reaction, and it is difficult to elicit, and it is usually not that important. Normally, during sleep, the pupils constrict. Okay, that is called as meiosis, sleep-induced meiosis. And in diabetes, the pupil may be sluggishly reacting, and it may be constricted. This is very, very important. Hutchinson's pupil. It is a clinical sign in which the pupil on the side of an intracranial mass lesion is dilated and unreactive to light because of the compression of oculomotor nerve on that side. And this may be because of concussion injury to the brain, and it may be associated with subdural hemorrhage and unconsciousness. So this is very important, friends. When you see a patient of head injury, and if the pupil in one eye is dilating or dilated, then it indicates that there is a seriousness of injury, and the patient might have to be operated. So, so these are the some of the stages of the Hutchinson pupil. So that is very important. So in head injury in unconscious patient, we have to always see the pupils. If the pupils are normally reacting and equaling sign, then usually there is no intracranial catastrophe. But if there is unequal pupil, it is very important, single most important physical sign that there is a herniated temporal lobe that is stretching the third nerve on that side, and prompt surgical treatment may be necessary. And bilateral dilated pupils usually, indicate a very grave disease, and it may also indicate that there is a brain death. And bilateral pinpoint pupil may be because of massive intrapontine hemorrhage or opiate poison. So thank you, friends. If you have any doubt in pupillary reaction, please don't hesitate to ask me. And I hope you have understood something about pupils from this lecture, especially how to elicit pupillary reaction. Thank you so much.